Get started. Thanks everyone for joining us. We're excited to be presenting to you on this really important topic. We've been hearing from a lot of folks in the business community about health insurance and the cost of health insurance. So thank you for joining CBIA and the Office of Health Strategy for this important event highlighting the agency's incredible progress in the last year implementing the Connecticut Healthcare Benchmark Initiative. We know that small businesses across the state are continuing to struggle to afford health insurance for their employees. Earlier this year, CBIA surveyed our membership and found that over 97% of our CBIA members are very concerned with the rising cost of healthcare. And we made it a mission this year to promote legislation that will make doing business and providing health insurance in Connecticut more accessible and affordable. The information and analysis that you'll hear today from OHS is a starting point for these public policy considerations, as we cannot improve the rising cost of healthcare until we expose the rising cost of healthcare. So I want to thank Director Veltri and her staff at OHS for making time today for the small business community to learn about important work their office is doing. CBIA is always a willing partner with state government to expose, target, and ultimately lower the cost of healthcare so our businesses can thrive, create jobs for their employees and for the residents of Connecticut. So I'm going to turn it over to Kelly from OHS to get started with the program. And again, thanks for everyone for joining. Kelly?
Yeah. Thank you, Chris. Hello, everyone. I'm Kelly Sinko. I'm the Director of Healthcare Innovation at the Office of Health Strategy. Thank you so much for having us here today. We're very grateful to CBIA for setting up this opportunity to share our office's work on Governor Lamont's Executive Order number 5. This order recognizes that healthcare costs in Connecticut are continuing to grow at a rate that outpaces the growth of Connecticut and regional economies, which of course, as you all know, impacts our state businesses. What we hope today that you will take away a better understanding of the state's efforts to control costs and improve the quality of care, as well as the underlying factors that are contributing most significantly to the healthcare spending growth. In addition to the benchmarking initiative that you're going to hear about today that was included in executive order, which is, the focus of today's topic, we wanted to let you know that our office remains committed to pursuing innovative strategies to build a comprehensive and cohesive healthcare vision for the state. We're going to take into consideration new and cutting edge reforms and ideas taking places in the areas of community health, health equity, health information technology, alternative payment and delivery models, and more. We want to continue to work hard for our residents and the crucial businesses and employers in our state to fulfill this vision and make healthcare more accessible, affordable, and higher quality. So with that, I'd like to thank you again for having us. And I very much look forward to hearing your viewpoints and questions on what you share with us today. And Michael, you can take it away.
Thank you, Kelly, and good afternoon, everyone. My name is Michael Bailit, and I have been working with OHS on the Healthcare Benchmark Initiative since its outset. So let me set up the slideshow for you, and I will present to you what I have to share today. Let me note as I do so that you are all invited to submit questions that you might have as we go along. So this is the agenda I'm going to cover. And as for questions, please feel free to put them into the Q&A box, and Kelly or I will answer your questions as they arise. So first, just a little bit of context on healthcare affordability in Connecticut. Why is OHS and the state more broadly focused on healthcare affordability? Well, Connecticut's healthcare costs are among the very highest in the country when we compare Connecticut to other states, and they are growing much faster than personal income. I'll note they're also growing much faster than the state economy. The problem is serious, and it gets worse year after year after year after year. And as small businesses, you know this because you see it in the unrelenting increases in premiums. In terms of the spending in Connecticut, well, you can see this is federal data from 2 different time periods, and both of them have Connecticut as one of the most expensive states for healthcare in the country in terms of spending per capita. Worse, worker contributions since the year 2000 have grown 2.5 times the rate of personal income. And that doesn't even tell the whole affordability story for workers, because out-of-pocket spending has grown even faster. Out-of-pocket spending is deductibles, co-insurance, co-payments. And so a larger and larger percentage of take-home pay, both reduced through premium contributions and through out-of-pocket spending, is going to healthcare spending, and hence isn't available for other needs. In addition, income growth in Connecticut has been slower than other countries. So having a high rate of growth is even worse when your income isn't growing very fast. So this sets all of the context for why this is important work. So let me talk a little bit about Executive Order 5, which Kelly referenced, and the process that OHS undertook starting about a year ago to address affordability and other state health priorities. So Executive Order 5 was issued by Governor Lamont in January of 2020. And it directed OHS to do a number of things. The first was to establish a cost growth benchmark for all payers and populations in the state for the time period 2021 to 2025. I'm going to explain what a cost growth benchmark is momentarily. It also required a strategy for getting to 10% of total healthcare spending going to primary care by 2025. It directed work to leverage the state's all payer claims database, that's what that acronym is, APCD, and other data sources to better understand what's driving spending and spending growth. And then finally, it directed the development of quality benchmarks for a 4-year period beginning this January. The process of developing recommendations to address these 4 charges was done with 2 advisory groups. The first, a body called the Technical Team, that consists of 10 state agency executives and outside stakeholders, but not insurers and not large health systems, was really the primary advisory body to OHS. But then there was a larger group referred to as the Stakeholder Advisory Board that was more representative, that it included providers, insurers, labor, foundations, consumer advocates, employers. They advised the technical team. And then finally, OHS has maintained an ongoing stakeholder engagement process in meetings like this, but also in smaller meetings as well. So that was the process to develop what I'm now going to share with you as the Healthcare Benchmark Initiative. So part 1 is the cost growth benchmark. You probably wonder, what is a cost growth benchmark? So it's a per capita target for annual spending growth. Per capita meaning per state resident. And the goal is to try to restrict spending growth so that it doesn't exceed the cost growth benchmark. I've already talked about the fact that healthcare spending is growing faster than other indicators. You can see that here. So this is Connecticut specific data. Per capita healthcare spending grew 4.1% 2015 to 2019 on average per year. And that's commercial coverage, employer-sponsored coverage, Medicaid, and Medicare, everything combined. The state economy grew 3.5%, so less than healthcare spending, and hourly wages grew only 2.6%. So, I mean, this is a problem in 3 boxes. So Connecticut is not the first or only state to be doing this, but it is one of the pioneers. The states that you see here in green have established cost growth benchmarks. Massachusetts was the first to do so in 2012. And there's been pretty rapid growth in the number of states doing this. New Jersey and Nevada are about to establish benchmarks, and California has active conversations underway. So the cost growth benchmark anchors a set of activities to slow healthcare spending. Having a benchmark in and of itself will not slow healthcare spending. But it does serve as an anchoring mechanism to a bunch of other complementary strategies that together should allow the state to achieve sustainably lower healthcare spending rates. So let me explain the logic behind all of this in a diagram. So here in the middle of our diagram is the cost growth benchmark. Again, it's a percentage growth amount for 5 years in the case of Connecticut. And so there are a bunch of complementary activities. The first is measuring performance relative to the cost growth benchmark. And in fact, OHS is involved in doing this right now for a baseline period. 2 is leveraging that all payer claims database and other data to understand what's driving healthcare spending. So we might find out through this measure activity whether or not the benchmark is being met or not, but we won't understand why. The analysis of the all payer claims database will allow us to understand why. The third step is to publicly report both performance against the benchmark and identify who's doing well and who isn't. I'll explain what I mean by who in a minute. And also to reveal what are the causes for spending growth. The fourth step is to then identify opportunities and strategies to slow growth. The opportunities should be revealed through this reporting and the analysis that underlies it. And then finally, there's implementation of strategies to slow cost growth. So you can see the cost growth benchmarks I described as an anchor. It's sort of a fulcrum for this set of iterative activities that are conducted year after year. So this is the logic for the cost growth benchmark. So let me explain a little bit about what the cost growth benchmark is for Connecticut, and then I'll talk about what do we know from other states about whether this works. So the technical team recommended to OHS that the cost growth benchmark be calculated as a weighted average of growth in the potential gross state product, which is really a long-range forecast of the state economy, and growth in median income in the state. And they recommended weighting forecasted gross state product 20% and forecasted median income 80%. And why did they weight median income more heavily? Is because they were focused on affordability for Connecticut residents. Resulting value is 2.9%. And OHS accepted and adopted the recommendation. OHS also took a recommendation from the technical team to increase the benchmark value for the first 2 years. So you can see for this year, it's 2.9 plus 0.5%. For next year, it's 2.9 plus 0.3%. And then it's 2.9 for the next 3 years. 2.9% is obviously far below what businesses see for premium increases from year to year. And I want to emphasize that there won't be a one-to-one equivalency, meaning you're not going to see your premiums growing exactly 2.9%, but the goal is to achieve accountability so that providers and insurers feel accountable to restricting spending growth for which they are responsible to these levels. The strategy adopted for Connecticut, while customized for the state, is very closely aligned with those developed by the states that preceded Connecticut, and that's Delaware, Massachusetts, Oregon, and Rhode Island. So a couple other things I want to note about the cost growth benchmark, and then I'm going to talk about experience in other states. The measurement of performance against the cost growth benchmark is to be done using aggregate spending to be provided by payers. When I say payers, I mean insurers, including those administering self-insured plans, the Medicaid program, and from the federal Medicare program. So it's not claim level detail, it's aggregate spending data. And the reason that it's coming from the payers is this is how the state can see in an aggregate form self-insured employer data, because otherwise the state wouldn't have a means to assess what's happening in the self-insured market, which is over 50% of the employer-sponsored coverage market. It also is a way to collect non-claims-based payment data and to get drug rebate data. This is consistent with what all the other states have done, this approach. The other thing I want to note is the Stakeholder Advisory Board had some concerns about potential underservice that could follow from having a cost growth benchmark. And so the technical team recommended that there be some monitoring strategies to see what impact the cost growth benchmark is having. I will note that No other states have found evidence of underservice, but it was a voice concern by the Stakeholder Advisory Board, especially from consumer advocates. And you can see these monitoring measures on the OHS website, as well as lots of other information about the Healthcare Benchmark Initiative. All right, so the big question I'm sure you are considering is, well, why do we think this will work? So there's only one state that really has many years of experience with this strategy, and it's Massachusetts. As I noted, Massachusetts established its cost growth benchmark in 2012, and we now have several years of data on their experience. So I want to share that experience. So they originally set their benchmark at 3.6, and then it dropped to 3.1. It was actually established in 2012 by their legislature. Between 2012 and 2019, the total spending growth was 3.6%. And actually, through the first 5 years, it was exactly at the benchmark level. So 3.6% is pretty good compared to historical spending, especially in Massachusetts, which traditionally has been the most expensive healthcare state in the country. But you can see the last 2 years, they've come in above their benchmark, and that's caused some concern. And just last week, the State's Health Policy Commission published some recommendations on additional steps to take to ensure better performance in the coming years. But I will say that if we pulled out, especially this last year, and we looked at the years that preceded it, Massachusetts has done pretty well in keeping its spending at a lower level than it had been, and then what was happening in other states. You can see a couple of years it was above here. One of the years was when the hepatitis C drug, Sovaldi, came out, but in other years they were well below the benchmark. Some more compelling information is what impact did this have on the employer-sponsored market or the commercial market? And there, the results are pretty impressive. So this is a graph looking at commercial spending growth. Orange is Massachusetts, blue is the US. You can see that prior to 2012, Massachusetts was above the US rate of growth every single year except 2009, and then just barely below. Ever since then, Massachusetts has been below the national rate by a pretty decent margin. And so this is an indication that particularly for the employer-sponsored coverage market, that having a healthcare benchmark, at least in Massachusetts, and I can't state more strongly that experience in one state does not predict experience in another state, because the market dynamics across the states are so distinctive. But at least in Massachusetts, it appears that this space right here between the blue and the orange lines from 2013 on was significant savings. And in fact, Massachusetts calculated this to be over $7 billion of savings to employers and employees. Now, spending didn't go down, right? These figures are still above zero and maybe higher than what anyone would want, but they were lower than they were in other states, and that's some indication of positive impact. So this is the strongest case for the potential benefit of the strategy in Connecticut. I say potential because it's not guaranteed, and especially for the employer-sponsored coverage market. So a little bit more about how this is going to be implemented. The other states all measure performance at 4 levels. State performance against the benchmark, market, and by that I mean insurance markets are the 3 markets: Medicaid, Medicare, and commercial. Commercial is inclusive of both fully insured and self-insured. Payer, and so that would mean insurers and TPAs for commercial, Medicare fee-for-service and Medicare Advantage plans, and the Medicaid fee-for-service program in the state. And then finally, provider entity. So what's a provider entity? A provider entity is going to be a large health system, a large medical group, perhaps an independent practice association, which is a group of independent practices that affiliate with one another. So there are multiple forms, but these are large provider organizations. And the plan is that spending performance relative to the benchmark will be publicly reported at all 4 of these levels. And when it's publicly reported, performance will be reported naming names. So we'll name the individual insurers, we'll name the individual provider entities and how they did relative to the cost growth benchmark, which is 3.4% for this year and 3.2% for next year, and then dropping down to 2.9. Kelly, I see we've got a question. Should we pause now and answer that one? Or is there not one?
Oh, there is one. Yep. Sorry,
Okay.
I'm just taking a look. So it says, given the strength of the private insurance industry in Connecticut, are you not concerned that is not a good comparison to Massachusetts? Do you want to take?
Yeah, so I mean, I think the biggest difference between Connecticut and Massachusetts is there are a couple of differences. I would say that the level of health system consolidation is greater in Connecticut. So this is not an insurance issue, it's a provider market issue. I think while Massachusetts got a fair amount of market consolidation, Connecticut has even more. That's one significant difference. And then as insurers will often say, there is less use of adoption of insurance products where in Connecticut, where consumers either enroll in an HMO or they enroll in another plan where they select a primary care provider. I think those are two significant differences. I don't know. I think the biggest difference in the health insurance industry is that Massachusetts is dominated by domestic health plans, meaning they are based in Massachusetts, and most, if not all, of their business is in Massachusetts, and they are nonprofits. Connecticut's health insurance market is dominated by publicly traded insurers that operate for the most part on a national basis. I think that's the difference in the insurance market. I don't know that I'm not sure that Connecticut's insurance market is, quote, stronger or weaker, but it's certainly different.
We have another question, Michael, as well.
Mm-hmm.
So unlike Connecticut, Massachusetts has focused on care transformation as a priority and invested in infrastructure reporting to manage its cap. How can Connecticut possibly hope to manage to a cap without a focus on care transformation and value-based payments that incentivize reduced costs and quality variation in the supply chain?
Yeah. So I don't think it's fair to say that Connecticut provider organizations haven't invested in care transformation. Could they do more? Yes. Could they do a lot more with value-based payment? Yes. I think Connecticut lags other states that way. There's no one way. I mean, there's a saying that many roads lead to Rome. Every state is different, and no other state looks just like Massachusetts. And the other states that have decided to pursue this strategy that you saw on the map, they're all doing it a little bit differently because they all have different environments. And there's no guarantee that any of this will work, but there's no question that there needs to be some discipline to create accountability for spending growth in the state, and there is none in Connecticut right now. So through the establishment of a benchmark and public transparency and accountability, there is a basis for beginning to create some accountability that hopefully will drive delivery system change and payment reform change. There are many different things that have to happen, but this can be an instigating activity. And I want to underscore, none of this is easy, but the status quo isn't working. And this is a strategy that at least shows some promise. Okay, so what's going on next? OHS is analyzing cost growth for the pre-benchmark period. So the payers all submitted data in June for 2018 and 2019. Purposely, we're looking at spending pre-COVID to establish the baseline. And if all goes well with the analysis, we've just been wrapping up validating the data from the payers. OHS will report the data publicly later this fall. The initial reporting is going to be at the state and market levels only. So no payer and provider organization performance this year, but next year, payer level and provider level performance will be reported. Obviously, the pandemic's having an impact on healthcare utilization, and so any results that are reported will note the impact on utilization and on spending. And under the governor's executive order, there are no prescribed punitive actions to be taken with entities that exceed the benchmark. There are some other states that have some actions, but those are in legislation, not in executive order. So right now, this is all about lots of naked transparency. All right, so I'm going to switch now to the next aspect of the cost growth benchmark initiative, which is the primary care spending target. So why establish a primary care spending target? Well, our healthcare system in the US is largely specialist oriented, in stark contrast to a lot of other countries. And there's a lot of research that shows that health systems that invest more in primary care relative to specialty care have better outcomes, lower costs, and patients have a better experience of care. So a number of states are focusing on primary care by first improving healthcare delivery and reinforcing the primary care infrastructure, which is not so healthy in Connecticut and in a lot of other states, and increasing the amount of spending that's allocated to primary care relative to all other services. So primary care spending target is the numerator definition is spending going to primary care. The denominator is all spending. And the executive order says, let's get to 10% as a percentage of total healthcare spending by 2025. This is comparable to what has been done in some other states. Rhode Island did this about a decade ago and got to 10%. And just this past legislative session, Delaware adopted something similar. Oregon also has a primary care spend target. Oh, and Colorado as well. Here too, no punitive actions be taken with payers that don't reach the annual target. And payers are really the accountable entity here, not provider organizations. So OHS set the 2021 value at 5%. The reason was OHS didn't have baseline data to identify current spending, although we had a best estimate for 2019 spending of being a little under 5%. The other reason was COVID-19 negatively impact primary care utilization in 2020, and that was anticipated to continue into 2021. So it was a conservative target for 2021. The technical team recommended deferring setting targets until collecting baseline payer data, which was just done, and consulting with a new primary care focused work group that's advising OHS. Data came in the summer. The work group's going to make recommendations probably in the next 2 months. And as with the cost growth benchmark, they'll be reporting at 4 levels, but again, the accountability is really at the payer level. All right, just a minute on quality benchmarks. So this is a corollary to the cost growth benchmarks. They are targets to maintain and improve healthcare quality in the state. The governor's executive order said that they can be any of a number of different types of measures, did not prescribe the actual measures to be used. Connecticut will be the second state to do this. Delaware was first. I expect others will follow, including some of the other cost growth benchmark states. So the quality benchmark development is the responsibility of OHS's Quality Council. It has been discussing benchmarks for its last 2 meetings, and I expect they're going to finalize them also in the next 2 months, and then they'll become effective January 1st. All right. The last part of the executive order I want to focus on is the data use strategy, and I actually have some data to share that you will find interesting. So the data use strategy is understanding, as I said earlier, what's driving healthcare spending, and it uses the all payer claims database and potentially other data sources. That logic model that I shared with you indicates that after the data analysis is done, there's opportunity identification and then convening of stakeholders to collaborate on strategies to address spending growth. That does not preclude unilateral action by any stakeholder, including the state, to address the cost growth drivers. So last fall and into early winter, I should say winter of 2021, I apologize, OHS had a contractor perform an initial analysis of all payer claims database data. And it provided some interesting insight into what's been driving spending and spending growth in the state. There's additional analysis that's to be completed this month that will give us additional insights and that are at a more nuanced level than what I'm going to share with you right now. But I do want to share with you some of the information that we've learned. So the analysis focused on the commercial market or the employer-sponsored market and found between 2015 and 2019, spending increased 21%. You can see the annual rate of change during this time period. It averages out to just under 5% a year growth. That's, again, higher than economic growth, way higher than wage growth. Now, I want to note, this includes cost sharing by employees and dependents. It doesn't include retail pharmacy. And retail pharmacy is a big portion of employer-sponsored coverage. So I just want to note that's a big omission. And that 5% annual growth or near 5% might be different if we included pharmacy spending, because pharmacy spending has been growing at a fast rate. What's also interesting is out-of-pocket spending by consumers grew much faster than overall spending. So you can see over this time period of 5 years, total spending, PMPM is per member per month, grew 21%, but out-of-pocket spending by consumers grew 28%. And you can see here the out-of-pocket percentages. The first year, 8%, then 13%, then it leveled off a little bit the next 2 years. And this reflects both employers trying to manage high premium growth by changing cost sharing in plan design and employees choosing plan designs with more cost sharing to limit their own premium deductions out of their paychecks. Right, so pretty bleak story for employees when you look at both the premium growth and what's going on with out-of-pocket spending. So why is it happening? So again, without pharmacy data, we broke down spending into a few categories. Professional spending, so this is physicians and non-physician professional, inpatient hospital acute care, outpatient hospital services, not ER, outpatient hospitals, ER, and anything else. So where's the spending going on? It's all in hospitals, right here. 6, 7, 8% a year growth. That's not 2015 to 2019, that's per year growth. Just pretty astounding rate of spending growth for hospital services. Professional services were growing 3% a year. That's pretty modest and probably acceptable by many measures, but the hospital spending much higher. So then you might ask, well, why is hospital spending growing? Well, we can figure that out. Here we look at percentage change in spending per unit for services, and then we look at changes in volume. The volume went down for hospital services, a full 10 percentage points for inpatient hospital services and for ER, a little under 1 for outpatient. So if spending is growing 6, 7, 8% a year and utilization is dropping 10%, what's going on? It's a change in spending per unit of service. So a unit of service for inpatient is a hospital discharge, admission discharge. So you can see the rate of increase 10, 7, 7, 9. That's per year. For ED visits, 9, 9, 12, 12, rounded, obviously. Just super high rates of growth. So does this mean prices are growing? Well, for the most part, yes. So we did some additional analysis that you can't see here. And this is a graph that just shows the difference between spending growth and utilization. What we found was that about 3/4 of the increase in price per unit was due to actual increases in prices that insurers were paying to hospitals. 1/4 was a change in the mix of services. And by that, I mean an increase in the intensity of the services. So most of that increase was hospitals being paid higher prices and being paid higher prices by insurers. Now, this analysis in the all payer claims database includes fully insured commercial business and state employees and dependents. Does not include non-state, and it doesn't include private employers who self-insure, because private insurers who self-insure do not submit claims to the all payer claims database. But that being said, I don't think we would expect to see trends that look much different, if different at all, in the self-insured employer market.
So Michael, we have a question.
Mm-hmm.
Doesn't the increased out-of-pocket also reflect that we have a predominance of publicly traded national insurers offering high deductible plans versus nonprofit options in Massachusetts?
So I don't think it has anything to do with publicly traded. I think but it does have to do with the plan design. So there's a movement all across the country towards high deductible plans, or if not high deductible, at least much increased cost sharing on the parts of consumers. And that does directly contribute to out-of-pocket spending. Massachusetts has done the same type of analysis that I've shared with you, and their out-of-pocket spending is growing as well. But I don't think that has anything to do with nonprofit versus for-profit plans. I think it just has to do with the plan design that employers are choosing and that employees are choosing when they have a choice. All right, one more finding. It turns out, and this isn't surprising, that chronic illnesses are common, and members who got chronic illnesses have far above average spending. So hyperlipidemia is high cholesterol. 16% of the population had it. That's per member per year spending is about $12,000. For the whole population, the average spending is $6,000. So basically, people with high cholesterol have spending that's double the full population of those commercially insured. And you can see for high blood pressure, arthritis, that we got spending levels are even higher. Depression, over twice as high. Diabetes, over twice as high. We also see that for people who have 2 or more conditions, spending is going to be more than twice as high. So the health status of the commercially covered population heavily influences spending. And the higher the prevalence of chronic conditions that you're going to have in your employee and dependent population, the higher your spendings are. All right, so this is just a little snippet of the analyses. There are many more and more to come that are giving us insight. But what we know is healthcare spending 2015 to 2019, excluding pharmacy, grew primarily because of hospital prices. Insurers are giving hospitals big rate increases. And that's what's driving up spending. We also know that prevalence of chronic conditions also significantly increases spending. There's other information that we know, and that will be shared by OHS in a number of forums, but I wanted to give you just a little feel, because these insights can help inform the development of strategies to try to mitigate cost growth. Because if we know what's driving spending, then we can do something about it. And we are developing a pretty good sense of what's driving spending in Connecticut. So, to that point, understanding is a prerequisite to correcting. We can take concrete action when we understand why healthcare spending is high, how it varies across the state, which we're also learning, and what's driving healthcare spending growth. So what OHS has planned next, just for this fall, there's going to be another report coming out, or 2 reports actually. One with the pre-benchmark trend analysis, so we'll learn what was the rate of per capita growth before the benchmark was established for the 2018-2019 time period. We're going to have a much deeper analysis of the role of hospital prices on commercial cost growth, and whose prices and for what services. We're also going to look into ED utilization disparities. I didn't share this information with you, but we found that in the employer market, that if we stratify data by looking at communities based on their profile, based on income and race, that lower income communities that are also less white tend to have ED utilization that is much, much higher than the highest income communities that are mostly all white. And so we're trying to understand why is that? What are the conditions that are leading to the visits? What's the chronic illness prevalence in the populations? Again, so that we can take steps to try to address the issues. In addition, OHS is going to publish a primary care roadmap. Roadmap equals strategy for improving primary care in the state and strengthening the primary care infrastructure so that there's a sustainable primary care base for the state for many years. And we'll seek payer support for its implementation. And then OHS will announce quality benchmarks effective January 1st. Oh, it says cost growth. It should be primary care spend targets for 2022 to 2025. All right, so I covered a lot of content. I'd like to pause now and invite you to add additional questions into the Q&A box, or comments or suggestions, whatever you'd like to share. Any reactions? Any recommendations you want to make to OHS, including ways to engage the business community? Jonathan, I see you have your hand raised. I think, though, Molly said that you all need to put your comments into the Q&A box. So if you're able to do that. Oh, no. Looks like you can
I
speak.
think I'm unmuted.
Yeah, all right, great, go ahead.
So thank you very much. This is really interesting and helpful. I guess if you go back to that last slide where you talked about a roadmap, I wonder if in your roadmap, you might consider some kind of commentary from OHS about helping independent providers maintain their independence, because I think that helps drive, I mean, there's a lot of different studies discussing that. And I think to that end, it might be worth having OHS discuss, different mechanisms by which independent providers, clinically integrated networks could negotiate, better insurance to keep themselves independent, and that kind of thing. Because I think that is integral in this, is if you lose the independent market, you're going to drive healthcare up. You're going to be having, hospitals and monolithic business primary care, whether that's Northeast Medical Group from a hospital or ProHealth from Optum. And I just think that doesn't seem like that's part of what you're talking about, but
I know it is. I didn't go very deeply into primary care, but OHS has a whole primary care work group that's been meeting for months. And OHS has been having lots of conversations with medical groups, large and small, and with payers. And there's a consistent theme that the small independent practices are in peril. The hospitals are buying them up and then charging much higher prices for their services. And that if there's a part of the primary care system that most needs support, it's the independent practices.
Yeah.
Thank you.
Oh, yeah. And just jumping in as well. That's a very important issue, Jonathan. So thank you for raising that question. We're actually, based on legislation that was passed last session, we're actually putting together a work group on physician practice mergers and acquisitions to kind of handle a little bit about what you just said. We're actually actively looking for participation. So on our website, if you are interested or anyone's interested, we're going to study methods to improve the oversight and regulation of mergers and acquisitions of physician practices, because I think what you said is really important and we need to address it. So just want to put that out there.
Okay, Jeff Hogan wrote, there are lots of large national employers in Connecticut who are already using tech-enabled advanced primary care to service their members via assignment. Most of these have virtual access that is convenient for members too, without being